are dependent on oxygen within the blood, and without this, they start to die after a few minutes, hence the maxim brain of its nutrition. In a hemorrhagic stroke, a weakened blood vessel ruptures, causing bleeding into the brain. Stroke symptoms therefore simply reflect the area of the brain that has been injured. A stroke is a stroke. There is no such thing as a partial stroke. That's just a consolatory term that's used for soft landing the diagnosis. Although recovery is possible, particularly with early intervention, stroke can result in lasting brain damage, long-term disability, or even death. There are several reasons why a stroke happens, but the most important risk factor of all is hypertension, also known as high blood pressure. The 10 key risk factors associated with stroke are high blood pressure, a sedentary lifestyle with lack of regular exercise, poor diet, high levels of bad LDL cholesterol, obesity, and abdominal adiposity, what we call pot belly, cigarette smoking, excessive alcohol consumption, irregular heartbeat known as atrial fibrillation, diabetes, and low income/low education. In addition to these factors, there are some risk factors that are not changeable, such as older age, having a family history of stroke, having had a previous stroke, male gender, and certain ethnic origins. As previously emphasized, the burden of stroke is enormous. The brunt of the burden is borne by sub-Saharan African countries, and indeed, every 2 minutes, one Nigerian dies from a stroke. Mr. Vice Chancellor, sir, recognizing that stroke is the single most important devastating neurological disorder affecting our population, our research group has conducted studies focused on clarifying the burden of stroke in Nigeria, understanding the role of factors that increase the risk of stroke, particularly hypertension, diabetes, and obesity, and exploring the determinants of outcome, death, and disability following acute stroke. I will also describe our efforts at translating these research findings into practice for the benefit of our patients. In acknowledgement of the void in data on the epidemiology of stroke in urban Nigeria, we applied for and received the University of Lagos Central Research Committee grant for the Epidemiology of Stroke in Lagos study to determine the prevalence and incidence of stroke in urban Lagos. The principal investigator of that study was Professor Mustafa Danesi. Collectively, these two studies bridged a 2-decade-wide void in published data on the incidence and prevalence of stroke in Nigeria, because there had been no prospective studies of that type since the late 80s. In the first phase of the EPICIL study, the prevalence study, we determined the prevalence of stroke in Nigeria to be 1.14 per thousand. Extrapolated to our current population, we estimate that there are at least about 250,000 Nigerians living with stroke. In phase 2, the incidence study, we established the incidence of stroke to be 54 per 100,000 per year. Again, the interpretation of this is that there are at least 100,000 strokes occurring annually in Nigeria. That is, 1 every 5 minutes. And these figures represent the very minimum. Mr. Vice Chancellor, sir, along with various colleagues, I have conducted studies that have looked at the role of high-impact risk factors, specifically hypertension, diabetes, and obesity, on stroke in Nigeria. Our research findings have been an eye-opener and have guided our approach to stroke prevention and treatment. I will briefly highlight the major findings from some of these studies. 1. Hypertension is indeed the major risk factor for stroke and is present in more than 75% of our patients. Secondly, the majority of our patients with stroke are previously diagnosed hypertensives. Multiple risk factors determine blood pressure control, particularly issues relating to the key players in BP control, that is the patients and the prescribers. Our studies have explored 3 related concepts. Between 2006 and 2007, in collaboration with my colleague Dr. Oluwatoyin Amira, Associate Professor and Consultant Nephrologist, we explored the prescribing patterns of antihypertensive drugs, factors influencing non-compliance to antihypertensive drug therapy, and the frequency of alternative and complementary medicine utilization amongst our patients. We found that blood pressure control rates are generally suboptimal, and acquisition costs of brand name drugs remain prohibitively high. More than 1/3 of our patients were not compliant to their antihypertensive medications. And of course, blood pressure control was significantly better in those who were compliant. A variety of reasons were given for this non-compliance. Financial constraints, side effects, and then miscellaneous factors. Mr. Vice Chancellor, sir, the variety of miscellaneous self-reported reasons for not complying to therapy, feeling unwell, forgetting the medication, fasting, travel, etc., indicates a need for us to improve patient education and counseling, modify our prescribing practice and consultation practices, and incorporate an evaluation of the financial means, perceptions, and cultural beliefs of patients when prescribing antihypertensive medications. We also established from these studies that complementary and alternative medicine use is frequent amongst people with hypertension, almost 40%, that herbal products are the main type of complementary medicine in use, and alternative medicine use occurs irrespective of socioeconomic class. We concluded from these studies that clinicians need to be aware of the practice, understand the rationale for this health-seeking behavior, proactively inquire about alternative medicine use, and counsel patients regarding any potential adverse events and interactions with prescribed medications. As some of us may already be aware, there has been a recent redefinition of the blood pressure reading used to define hypertension. Hypertension is now defined as a systolic blood pressure, that is the upper reading, at or above 130, and a diastolic blood pressure, the lower reading, at or above 80. In order to help us better understand the magnitude of the blood pressure problem in our nation, I most recently brought together a group of colleagues to conduct an updated study on the prevalence of hypertension in urban Lagos. To the credit of all the collaborators, we used personal funds to develop the protocol, train and pay field workers, and conduct the data analysis. Mr. Vice Chancellor, sir, I am proud and delighted to state that we achieved our target, and I'm able to share the data with us today. The major findings from our preliminary data analysis for our nearly 5,000 urban dwelling adults is a real wake-up call. Firstly, more than half, 55.8%, have hypertension. Secondly, the average blood pressure of our urban adult population is in the range defined as elevated blood pressure. And thirdly, only about 1/3 of the population have normal blood pressure below 120 and below 80. Mr. Vice Chancellor, sir, we have also studied other stroke risk factors, particularly diabetes, obesity, and abdominal adiposity that I described as mid-belly fat or post-belly. Our main findings in this arena have been as follows. Hypertension occurring together with diabetes is more frequently encountered in women compared to men. Secondly, as weight increases, the tendency for diabetes and hypertension to coexist increases, and that is shown in this slide. We also documented a gender disparity. Both obesity and abdominal adiposity are commoner in women with diabetes compared to men. In addition, amongst obese persons, the magnitude or severity of obesity and abdominal adiposity is much higher in females. Mr. Vice Chancellor, sir, in order to reduce death and disability from stroke, it is imperative that we understand what factors predict these outcomes when the unfortunate happens and a stroke occurs. Our research group has also been engaged in exploring these determinants. Our studies have found that at the time of a stroke, during the acute period, having a normal or very high blood pressure worsens outcome within the early days following stroke. Sir, this seemingly paradoxical finding corroborates data from other centers worldwide and has continued to reflect in guideline recommendations reiterating cautious and selective blood pressure management in the acute post-stroke period, particularly for ischemic strokes. We have also demonstrated from our previous studies that the strongest predictor of death within 30 days of acute ischemic stroke is the presence of complications. The highest death rate was in those who had aspiration pneumonitis. That is, they were fed following the stroke and it went down the wrong passage. As a consequence, we now routinely ensure that tests for swallowing are conducted in all our conscious patients upon admission, and that no feeding by mouth occurs until the patient is certified fit to swallow safely. Other strong predictors of an increase in death rates following a stroke include the presence of infections, elevated blood sugar levels on admission in ischemic stroke, the presence of loss of consciousness in hemorrhagic stroke, and a composite score known as the ICH score that combines clinical parameters and brain imaging parameters for hemorrhagic stroke. These studies have strongly influenced our current practice, where interventions are in place to reduce complication rates, particularly for aspiration pneumonitis and infection, and closely monitor the more severe strokes and control blood glucose levels proactively. Mr. Vice Chancellor, sir, another focus of our outcomes research has been directed at the role of blood biomarkers. Blood protein biomarkers are chemicals that can give us insight into how the body responds to the assault of a stroke. This knowledge can be applied to finding drugs or treatments. I was fortunate to receive a University of Lagos Central Research Committee grant to study two such biomarkers, homocysteine and C-reactive protein. In addition, one of our residents at the time, now an associate professor of neurology and consultant neurologist, Dr. Abubakar, extended the CRP study as his Part 2 dissertation. The homocysteine study was largely negative. There was no association with stroke. On the contrary, the elevated CRP levels were strongly associated with stroke and with higher case fatality and worse disability. Our research team has a strong interest in pursuing this area of preliminary study, and currently, Dr. Lara Ojo has a BRAINS grant where she is conducting some preliminary studies on biomarkers. We have applied for and are hopeful that TED Fund will provide the much needed grant funds for the largest study. We received some sharing information in December 2017 in the form of an invitation to progress to phase 2 of the TED Fund National Research Fund proposal screening, and are waiting very, very patiently for further direction. We pray that our expectations will not be cut off. Mr. Vice Chancellor, sir, the value of medical research is in implementation for end-user impact, extending, adopting, and adapting research experience to improve the quality of care and outcomes. Bearing this in mind, our understanding of the stroke burden and needs has led to several initiatives. This includes public awareness and enlightenment, different World Stroke Day programs, press conferences, health screens have been conducted by our unit, healthcare provider education. We have continued to educate the public and so forth in seminars and workshops, continuous refinement of our unit treatment protocols, and monitoring for service improvement using our Loop Stroke Registry. This is in addition to passing on knowledge to students and resident doctors. These are some of the World Stroke Day activities and the World Stroke Day press conference. Mr. Vice Chancellor, sir, the most important contribution, however, has been the establishment of the Loop Acute Stroke Unit. Our clinical observations and formal research have unequivocally demonstrated to us the positive impact of structured, multidisciplinary care in improving outcomes following stroke. There is strong evidence that organized stroke unit care, preferably based in a discrete ward, saves lives. On this basis, and with the resolute support of the Loop administration, under the current Chief Medical Director, Professor Chris Bode, we established a first-of-its-kind Loop Acute Stroke Unit, taking in our first patient in mid-June 2017. The unit was formally commissioned by the Honorable Minister of Health, Professor Isaac Folorunsho-Adewale, on Tuesday, the 1st of August 2017. This multidisciplinary unit has a retinue of about 18 nurses, neurophysiotherapists, 3 neurosurgeons, 5 neurologists, a strong team of dedicated senior registrars in neurology and neurosurgery, neuroradiologists, and rotating residents and interns in internal medicine. We also have support administrative, technical, and nurse assistant staff. Most of the funding for this center has come from internally generated revenue, made available by the management, generously discounted brain CT scan rates, alongside a few philanthropic donations from well-meaning Nigerians and organizations. And I want to particularly thank my friend, the wife of the Deputy Governor of Delta State, Engineer Njideka Ulunma, for her continuing support of our unit. Thank you, Madam. This has enabled us to sustain our model of admission without charge. We treat first and the patients pay minimally later, allowing us to implement care early. Our preliminary experience has demonstrated the need to replicate these centers nationwide, but also educate the public to recognize the warning signs of stroke and the importance of early presentation to hospital. It has also become glaring that beyond acute stroke unit care, post-care in the early rehabilitation period mandates the establishment of dedicated stroke wards to extend the gains of the acute stroke unit. I again salute the LUF CMD, Professor Chris Bode, who has committed to making this a reality in the very near future. I invite public-spirited and philanthropic individuals and organizations to key in and partner with LUF in safeguarding the brain health of our population through this initiative. Mr. Vice Chancellor, sir, I will now describe what I regard as my better research and professional half, where my heart lies. When I delved into this subspecialty of movement disorders, it felt like I was groping in the dark, majoring on the minor. This serendipitous journey has, however, become the most exciting aspect of my career, giving me the greatest fulfillment in engaging in what I find to be the utmost opportunity to share knowledge and make a positive impact on the lives of those that live with movement disorders. What are these movement disorders? They are a subgroup of neurological disorders characterized by either excessive movement or reduction of voluntary and automatic movement unrelated to muscle weakness or stiffness. Examples include Parkinson's disease, Parkinsonism, tremors, dystonia, chorea, athetosis, Ballism, tics, ataxia, restless leg syndrome, and many other things that sound really funny. Principally, they arise from disruption of the function of the basal ganglia, its connections, and the closely allied cerebellum. To the neurologist, they are a fascinating panoply, a magnificent or impressive array of shapes, twists, and turns. To the patients, they are a cause of disability and impaired quality of life. Mr. Vice Chancellor, sir, as for all aspects of my career, I believe my expedition into this subspecialty was divinely orchestrated. While in earnest search of a dissertation topic in 1995-96, I approached Professor Kayode Odushote, a neurologist par excellence, and then Executive Secretary of the West African Postgraduate Medical College. It was he who suggested that I consider conducting my fellowship research on Parkinson's disease and start by establishing the feasibility of such a study by having a clinic database of all cases. And yet again, the trust in those ahead of me did not disappoint. My observation is that whereas these conditions abound in our environment, they remain largely unrecognized, underdiagnosed, and undertreated. These are some of my research findings and contributions to the field to date. Mr. Vice Chancellor, sir, I have researched the epidemiology of movement disorders, clinical profile, genetics, and access to medicines in Parkinson's disease. I have also made trips for movement disorders, translating my research into practice. Parkinson's disease is the most important and most common degenerative movement disorder. In early 2005, while at the Mayo Clinic in Rochester, as a visiting clinician in movement disorders, I conducted a systematic review to document the status of Parkinson's disease research in Africa, focusing on epidemiologic and genetic studies published over a 60-year period from 1944 to 2004. The results showed at the time that there were only 28 such publications from 13 African countries. None of the genetic studies had been conducted in Black Africans, and there were no case control or cohort studies. One of the glaring findings of that report was the information gap that needed to be filled and the potential areas for future research. Essential tremor, on the other hand, is the most common pathological tremor in humans and one of the most frequently encountered movement disorders in clinical practice. In 2008, we conducted the first ever community-based prevalence study on essential tremor and determined its prevalence to be 23.8 per thousand. Extrapolated, this indicates that at least 4.6 million Nigerians may have essential tremor. That may explain the abundance of poor handwritings and irregular signatures in our society. Another study based on our outpatient clinic population concluded that the clinical profile of Parkinson's disease in Nigerians is indeed similar to that in other populations. However, was characterized by delayed presentation to specialist care, as has been described in other developing countries. You will notice that our patients typically present about 2 years into the course of their clinical symptoms. We have also conducted a series of other studies that have explored other less researched aspects of Parkinson's disease, including cognitive function, depression, autonomic dysfunction, quality of life predictors, longitudinal mortality, and so forth. The importance of these studies is that they have provided data for comparison with other populations, bridged some gaps of information on Parkinson's disease in Africans, and demonstrated similarity with other global populations. Mr. Vice Chancellor, sir, a vital aspect of understanding Parkinson's disease is determining what exactly causes it. The predominant theory is that there is an interplay between inheritance, that is genetics, and environmental exposures. Following up on my earlier observations, I conducted another review solely focused on the genetics of Parkinson's disease in Africa, and this was published as a lead article in one of the foremost specialty journals at the time. The publication exposed the paucity of data on genetics of Parkinson's disease in Africa, with the majority of studies emanating from North Africa. As a response to this void in knowledge, and building on my exposure to a research group focused on genetics of Parkinson's disease in North America at the Mayo Clinic in Rochester, I became determined to document the first case control study of the genetics of Parkinson's disease in sub-Saharan Africa.